Okay. Speak like this, speak now. You start from the beginning. Just say a few things, say whether that's audible.
Hello, am I audible?
Yes. Audible now. It's audible. Let's start. So you can start from the beginning, no?
Yeah, start from the first slide.
Okay.
This
Just keep it.
a popular line goes, the moment a newborn takes a first breath, things change. This is true for both parents and professionals because any impediment in this complex transitional physiology may lead to a potential life-threatening situation, extended hospitalization, or long-term consequences. Here, I would like to spotlight the AMH perinatology team who have handled successfully the entire spectrum of neonatal respiratory distress. So these are a few cases from the NICU files. The first case is of an abruptio at 28 weeks with a birth weight of 1.9 kgs, successfully treated with surfactants. The next one is a preterm birth, 29 weeks at 1.2 kgs, which is a very low birth weight baby, also treated successfully. A case of selective growth restriction in a twin pregnancy at 32 weeks. The cause was uteroplacental insufficiency, birth weight 1.8 kgs. There was another one with meconium aspiration and sepsis. Few cases of gestational diabetes with fetal distress at 2.4 kgs. And the last one, at 37 weeks, a macrosomic baby, 4.6 kgs, presenting on admission with hypoglycemia and polycythemia and neonatal respiratory distress. An operational definition of respiratory distress would be abnormal respiratory rate, labored respiration with or without cyanosis, presenting as an emergency in the first few minutes of birth. Respiratory distress syndrome is, however, a separate entity, a distinct entity related to prematurity of the lungs. Current statistics state a global incidence of 6.7%, with a trend towards low, very low, and extremely low birth weight neonates. The recent COVID pandemic put forth a high incidence of preterm and growth-restricted fetuses. The implications of still are being studied. Unfavorable outcomes well into the pediatric age group and adulthood, like bronchopulmonary dysplasia, cardiovascular, and neurosensory deficits, have been recorded by factors either predisposing, causing, or consequential to neonatal respiratory distress. The European Society for Pediatric Research and the Union of European Neonatal and Perinatal Societies have endorsed guidelines which aim to optimize outcomes for at-risk fetuses. Today, the gold standards of lecithin surfactant ratio, phosphatidylglycerol levels, and surfactant proteins A and B in the amniotic fluid biochemistry are performed less as USG has scored over these methods. Ultrasound has always been the mainstay in antenatal care, being non-invasive, available at the point of care, and due to its real-time capability. With rapidly evolving research and management techniques, multiple predictors and prognosticators have evolved and widely been applied. Normograms and reference thresholds have been charted according to the gestational age, So clearly, there is a shift from preventive to predictive medicine. So I welcome you all today to this pediatric CME of antenatal USG predictors of respiratory distress in a neonate. A bit about the embryology. The thoracic cage and diaphragm are formed by the 12th week. The lungs, primary organ of gas exchange, passes through these developmental stages. The pseudoglandular stage of bronchogenesis, the canalicular stage where immature alveoli are vascularized, and the saccular stage starting at 26 weeks when type 2 pneumocytes start producing surfactant proteins. At 36 weeks gestational age, alveoli mature, vascularization is integrated, and optimal surfactant starts getting produced, ready for gas exchange at birth. Cardia starts as a convoluted tube, develops into a 4-chamber pump, and remarkably, at 16 weeks, there is a structural and functional sync between the two due to the 3 important shunts at the ductus venosus, the foramen ovale, and the ductus arteriosus. Shunt physiology is very necessary for fetal survival, and it goes a wide range of adaptive changes during adversity in utero. Such prenatal adaptations have been found to increase the risk of an impaired cardiorespiratory vascular transition at birth and may also persist postnatally. Multiple causes of respiratory distress can be classified, first of all, as pulmonary causes, which could be parenchymal, where we have the transient tachypnea of the newborn, meconium aspiration syndrome, respiratory distress syndrome, pneumonias. There could be developmental abnormalities like pulmonary sequestration, cystic adenomatoid malformation, congenital diaphragmatic hernias, tracheoesophageal fistulae, and pulmonary hypoplasia. Airway abnormalities, stenosis of the larynx, the subglottic trachea or bronchus. Mechanical abnormalities, thoracic dystrophies, and constriction of the mediastinum by pneumothorax or pneumomediastinum. Cardiovascular causes would include systemic obstructions, cyanotic mixing lesions, vascular slings causing tracheal compression, high output states like CCF and anemia or vein of Galen malformation, cardiac arrhythmias, and myocardial dysfunction are also important causes, notably in metabolic derangements like diabetes and hypoxic insults. Other causes include metabolic dysglycemia, hematologic causes like polycythemia, and neurologic causes of perinatal asphyxia, which mainly present as apnea. Ultrasound has a singular role in isolating and selecting the high-risk group and conducting serial surveillance till the most favorable outcome is achieved for the particular fetus. So we step into the early anomaly scan. At 11 to 13 weeks, nuchal scan. Important indicators like multiplicity of the gestation and their chorionicity, aneuploidies, and risk of preeclampsia by way of the mean uterine artery PI can be diagnosed. Early cardiovascular and pulmonary developmental spondylothoracic diaphragmatic anomalies also can be investigated. Here we show the integrity of the diaphragm, the thoracic cage, and the nuchal thickness for aneuploidies. Few such examples at this gestational age could be congenital diaphragmatic hernia, wherein in an axial section, bowel loops are seen at the same level as the heart. There are aneuploidies and placental causes like placenta previa in a twin pregnancy or early cardiovascular anomalies showing reversal in the A wave in one of the fetuses of a twin pregnancy. Lung masses like CCAMs, that is congenital cystic adenomatoid malformations, also can be seen at this gestation. pulmonary manifestations of genetic disorders, which are hypoplasia in trisomy 13 or 18, bronchopulmonary sequestration in trisomy 21 are also seen. The next pit stop at 14 to 16 weeks is a screening for cervical incompetence, especially so for high-risk pregnancies like multiparity, previous history of os incompetence, polyhydramnios, and multiple pregnancies. These are cases at high risk of spontaneous premature labor or worse, a precipitous preterm birth. Assessment includes the functional length of the cervix, which is the closed cervical length. Anything less than 2.5 centimeters is significant and below 1.5 centimeters is critical. This has been extensively studied and found to have a positive predictive value of up to 83%. An earlier dictum of 2 mm dilated cervical canal for a length of 2 centimeters is infrequently used today. Instead, herniation of the sac up to 15% or more of total cervical length with various configurations like the T, U, V configurations. For example, this one could be a Y, this one could be a V. So these configurations are important. Uterocervical angle is the next indicator. More than 105 degrees can assess cerclage failure risk. Real-time sliding can be useful in pregnancies complicated with pre-existing deep invasive endometriosis, cervical myomas, or in retroversion of uterus. A cervical consistency index is the anteroposterior compressed length on manual compression divided by the resting length into 100. The cutoffs vary depending on gestational age and history. A significantly low CCI value of less than 60% warrants close monitoring and preventive intervention. Shear wave elastography has been extensively studied, and lower shear wave velocity or lower kPa values is strongly associated with an increased risk of spontaneous preterm delivery. By 20 weeks, the structural anatomy can be delineated. A quick upper respiratory scan would typically involve demonstrating the nasolabial and oronasal folds, integrity of these, hard and soft palate, uvula. When these are parallel, they are indicative of the absence of cleft palate. Retronasal choanae, the tongue, pharynx, the laryngeal compartment, supraglottic trachea, and the trachea in the cervical region. Examination of the lower respiratory tract involves demonstrating mediastinal trachea. If you see this is the trachea, and this is the esophagus. This is the aorta, and that is probably the SVC. So here you can see the bifurcation of the trachea into at the carinal level, and further down, this is also the carina, and further down at the hilum. The thymus is seen in the anterior mediastinum at the 3-vessel trachea view, and this is seen as a hypoechoic structure which is lined by the internal mammary artery branches, also called the thymus box. A visual assessment of thoracic cage volume, pectus abnormalities, and peripheral bronchioles, depending on the visibility, is also assessed. An important subjective predictor here is the lung is to liver echogenicity ratio, which is always more than 1. So the lungs being a little more echogenic than the liver. 20 weeks is also the expected time of integration of vasculature into the parenchyma. Mediastinal vessels and their relative position to other structures can be determined up to the hilar and secondary bronchiole level. Here we see the main pulmonary trunk dividing into the right and left main pulmonary arteries, the aorta and the SVC in its normal configuration. This is at the level of the hilum. You can see air-filled bronchus with the pulmonary vessels. the superior and inferior pair of pulmonary veins draining into the left atrium. Here, this is the fluid-filled esophagus just in front of the aorta. There is the azygous vein. These are important for tracheoesophageal anomalies and IVC, interrupted IVC abnormalities. If visibility permits, we can see the peripheral the vascular supply to the peripheral pulmonary parenchyma. Estimation of thoracic circumference and abdominal circumference, where thoracic circumference is not less than 20% of the abdominal circumference, is a good indicator. Many cases of pulmonary hypoplasia and thoracic dystrophies, or both, can be diagnosed with this ratio. This is a simple algorithm for lung parenchymal lesions detected in utero. If the fetal lung is small, generally it is hypoplastic. If there is a larger lung volume, depending on the echogenicity, which is normal, if it is normal, it could be a congenital lobar emphysema or a bronchoagenesis. If it is predominantly cystic, it could be a CPAM, which is macrocystic. Predominantly solid ones are the microcystic variety of CPAM or bronchopulmonary sequestration. Antenatal steroid therapy for a select group of CPAM can be started at this or considered at this stage. Fetal interventions like fetal endoscopic tracheal occlusion for severe congenital diaphragmatic hernia to promote lung growth can be done at this stage. Laser coagulation for bronchopulmonary sequestrations have been tried. Radiofrequency ablation for fetal mediastinal tumors, thoracoamniotic shunts for macrocystic CPAMs, and also there is an upcoming concept of exit, which is the ex utero intrapartum treatment, where the child, while being attached, or the fetus, which is while being attached to the placenta, is delivered by cesarean, secured the airway, and delivered later. Cardiovascular anomalies are diagnosed mainly by the standard views, and there are a wide range of abnormalities beyond the scope of this discussion. However, I would like to share a few abnormalities seen in the course of the last year: an isolated pulmonary stenosis, a suspected vein of Galen malformation, some nodal dysfunction, and two vascular anomalies, which are right aortic arch with a left ductus arteriosus and an aberrant right subclavian artery, both of which could create vascular slings around the trachea, causing compression. The physiological development can be demonstrated by various movements in real-time scanning, like practice breathing, diaphragmatic movements, any reflux on swallowing or thumb sucking. These can indicate good neuromuscular coordination, presence or absence of palatal anomalies, and tracheoesophageal anomalies. The concept of placenta-brain-cardia axis. This says that since placenta, brain, and cardia are the earliest organs to develop, this is widely regarded based on their shared developmental pathways and hence are thought to be hemodynamically intertwined. It is well documented that disruption in one can affect the others, and this axis comes into play in hypoxic and metabolic dysregulation. Hence, a synergistic evaluation incorporated into prenatal care can significantly improve risk assessment. Imaging the placenta involves a thickness and texture and vascular impedance in the uterine arteries. Lakes and lacunae. Lakes are venous spaces with slow blood flow, but lacunae usually give a Swiss cheese appearance with high turbulent flow, indicative of the Acarita spectrum. Scanning for infarcts and thrombosis in the placenta is definitely valid in maternal morbidities like hypertension, diabetes, chronic nephritis, microangiopathy, SLE, and coagulopathies. Thrombosis and infarcts were the most commonly seen feature in the COVID pandemic resulting in growth-restricted fetuses and preterm births. Mesenchymal and angiomatous dysplasias and umbilical vein varices can result in high cardiac output and volume overloads. Polyhydramnios is associated with high output states and high airway obstructions. Oligohydramnios is associated with pulmonary hypoplasia and growth restriction. Amniotic fluid turbidity can show either passage of meconium or hemorrhage as in abruptio or vasa previa. Miscellaneous conditions like immune, non-immune hydrops and obstetric emergencies like cord compression, cord around the neck, previous scar dehiscence, or uterine rupture, especially in macrosomic, polyhydramniotic, or multiple gestations, add to the list of this target high-risk group for respiratory distress. In clinical practice, the commonest encountered fetal scenarios are that of growth restriction, mostly due to uteroplacental insufficiency in their various grades of severity, prematurity, metabolic milieu abnormalities, especially dysglycemia, maternal clinical scenarios like previous cesareans or comorbidities, and chromosomal developmental abnormalities, mostly which are compatible with life. And the others could be hemodynamic or decompensations, cardiac failure due to degrees of severity. So we have possible gestational outcomes as either a precipitous preterm delivery, again giving us an extremely low birth weight, very low birth weight or a low birth weight fetus, emergency cesarean section, again giving the same outcome, or an elective cesarean section, which can delay, prepare, and deliver, which might just give us a transient tachypnea, respiratory distress syndrome, and a manageable pulmonary primary hypertension. The third trimester is a time for ascertaining growth trend, reevaluation for evolving structural abnormalities, and any uteroplacental mismatch. Also for organ maturity and functionality indicators, especially the lung and the cardia, in preparation for major stress and transition at birth. Biometry, which is known to increase with GA and fetal weight, correlates with reduced incidence of respiratory distress. Presence of free-floating particles called vernix caseosa in the liquor, Granum's grades of placental calcification, visualization of ossification centers of long bones, thalamic and colonic echogenicity, and the lung-liver echogenicity are few of these indicators. However, these are not organ-specific and correlate more to gestational age rather than being organ-specific. Variability in their validity is seen in maternal diseases, and these are not reliable in the preterm, very low birth weight or extremely low birth weight groups. Over the last decade, multiple organ-specific predictors have evolved, case in point the lungs, cardia, and specific others. Lung volumetry was originally developed for congenital diaphragmatic hernia, further extended to respiratory distress. This is calculated as a product of all the lung dimensions multiplied by 0.5. So we get a volume value, which is matched by gestation adjusted reference threshold levels. Less than 35% of the GA adjusted values is a poor prognosticator, and a cutoff critical value of 32 centimeter cube, which is approximately 1/3 the volume of the right hemithorax, is said to be a clear predictor of neonatal respiratory distress. In case of presence of lung masses, a ratio called congenital lung malformation volume ratio, which is calculated by the volume of the abnormal lung by the head circumference, is used. A CVR of less than 1.1 is supposed to be low risk. These lesions are monitored every 3 weeks. And if the CVR is more than 1.1, there is a high risk which mandates weekly to biweekly follow-up due to elevated risk of fluid accumulation, development of hydrops, esophageal compression, or mediastinal shifts. These ratios may form criteria for exploring in utero surgical interventions, as discussed earlier. In healthy fetuses, diameters of vessels have a linear increase through the second and third trimesters. Ratios and relative sizes are more often used rather than actual measurements. However, normograms are available for these measurements. For example, the main pulmonary artery is measured as 2.7 plus 3 millimeters per week of gestation after 20 weeks. Similarly, the right and the left pulmonary arteries have measurements. The pulmonary artery to aorta ratio is always 1 with a mild larger diameter of the pulmonary artery than the aorta. With progressive peripheral angiogenesis and alveolar integration, maturation of peripheral vascular smooth muscle progresses and pulmonary arterial vascular resistance decreases. This is the basis of incorporating vascular Doppler indices of the main pulmonary artery to assess lung maturity. MPA trace, the main pulmonary artery trace, is typically a needle-shaped systolic, it has a needle-shaped systolic peak with rapid systolic acceleration and a forward flow that continues through the diastole. From 26 to 36 weeks, increasing RVOT output and the peak systolic velocity with lowered PI and RI values are noted. Multiple studies report clinical utility of these indices in prediction of respiratory morbidity, particularly in growth-restricted and preterm fetuses. Multiple combinations of parameters, including lung volumetry with MPA Doppler parameters, or cervical shear wave elastography with MPA Doppler parameters, are evaluated as predictors. So this is just to show at 20 weeks, the main pulmonary artery trace, and at 36 weeks, it kind of broadens out, the peak systolic velocity increases, the pulsatility decreases, and the AT and ET ratios. So we calculate the acceleration time by start of systole to peak of systole, the time which is taken from start of systole to peak of systole, and the ejection time from the start of systole to the end of systole, which gives us this ratio called AT by ET ratio. The cutoff is 0.3 at 34 to 39 weeks. Due to consistent correlation with neonatal distress and matching results of surfactant to albumin ratio in amniocentesis, it is highly recommended to include this parameter for fetal lung maturity before considering delivery. Velocities may be high in high cardiac output states or low in pulmonary stenosis, like in this one. The pulmonary artery velocities are almost touching 200. This is a case of pulmonary stenosis. Power Doppler imaging provides important information about lung perfusion. Visualization of less than 3 vascular branchings on a 2D image predicted primary pulmonary artery hypertension in neonates. Volume rendered perfusion indices less than 25% of documented normograms as per GA are supposed to be good indicators. Increased RI of intrapulmonary arteries correlated also with lung maturity. Microvascular flow imaging is an emerging third-generation Doppler technology that provides high-resolution, non-invasive visualization of slow blood flow in the peripheral lung. Vascularity index is defined as the percentage of colored flow signal pixels within a manually drawn region of interest on a microvascular flow image. This is just to show how a B mode, a color Doppler, a power Doppler, and a microvascular flow can show peripheral lung vascularity best. And you see that this increases over the gestation period. Normograms describe GA-dependent increase in the vascular index. The pseudoglandular stage has 42% of peripheral lung perfusion, whereas the saccular and the alveolar stages at 35 weeks can have up to 96% of vascular perfusion. Low prenatal vascular indices emerged as an independent predictor of neonatal respiratory distress, suggesting that deficits in the fetal pulmonary microvascular development contribute to postnatal respiratory morbidity. Recently, radionomics have been used with AI computation, have been used to study the lung texture and integrated these into other predictors to improve consistency for these predictors. Lungs have to grow, vascularize, and mature to get functional. In contrast, the cardia has to pump consistently while bearing the brunt of hemodynamic pressure and volume overloads. And it does so by adapting, compensating, and remodeling itself before the signs of failure begin to appear. Hence, cardiac assessment has an important role to play in antenatal evaluation of high-risk pregnancies. Important in this is a review of structure and the hemodynamics of the cardia, calculating the right and left ventricular outputs, identifying signs of systolic and diastolic dysfunction, adaptive signs, and rhythm abnormalities. Various modes of examination, including the B mode, color spectral Dopplers, M mode, and 3D echocardiography can be done. Not to forget the shunts, the important shunts, which are the ductus arteriosus, the foramen ovale, and the ductus venosus. The clue to dysfunction lies in abnormal flow through these shunts. Increased flow through the ductus arteriosus is due to right-sided abnormality, and increase through the foramen ovale indicates a left-sided abnormality. Assessment of the systolic function. Systolic function is a contractile status of the heart. So this is done by on the M mode, it is done by calculating the shortening fraction and the ejection fraction of ventricles. In fetus, right ventricular volume is always more than the left ventricular volume, but the left ventricular ejection fraction is more than the right ventricular ejection fraction. Stroke volumes and cardiac output for each ventricle are calculated with the help of velocity time integral multiplied by pi r square, and the cardiac output multiplied by the fetal heart rate. Septal and ventricular wall hypertrophy and their movements are also can also be assessed. The annular displacement of the valves, the linear displacement of valves from the annulus, is also calculated with the help of M mode. Myocardial contractility can be seen through a tissue Doppler, and rhythm abnormalities on a long trace. All these have normograms, and all these through their gestational ages, and can be compared with the reference thresholds. Diastolic function is the filling capacity of the ventricles, which increases with gestational age. Flow through the AV valves, that is the tricuspid and the mitral valves, typically have an E wave and an A wave. This is the E wave and the A wave. E wave is always smaller than the A wave in normal healthy fetuses. It is also called the characteristic biphasic, two distinct peaks with a wave, with the the A wave higher than the E wave. The E wave typically is 16 to 50 centimeters per second velocity, and the A wave has 30 to 50 centimeters per second velocity, increases with gestational age. E by A ratio is always less than 1 in fetal life. The E wave and A wave at times may become similar in height or may fuse, giving a monophasic pattern, which is indicative of loss of atrial compliance in diastolic dysfunction. We also can estimate flow through the IVC, sometimes showing regurgitant flow, which could be due to diastolic dysfunction. Adaptive signs are important because these appear much before the extracardiac Doppler findings to suggest uteroplacental insufficiency, and presence of these findings can flag fetal distress, warrant close fetal surveillance. In hypoxemia, the B mode shows a globular appearance because of diastolic dysfunction. Increased isometric relaxation times and contraction times can give us an idea about the diastolic and the systolic function. Especially in hypoxemia, there is a progressive decrease in the peak systolic velocity of cardiac outflow tracks, a decline in the left and right cardiac output, reduced diastolic function, seen as lower transmitral E wave, reduced A wave, and as the insult progresses, there is reduced E by A ratio, left ventricular hypertrophy, and at times, just like we have brain sparing effect, we have a coronary sparing effect, and some coronaries may be prominently seen. In pregnancies complicated by gestational diabetes, it is possible to identify early cardiac adaptations and guide clinical management in the form of stricter glycemic control and tailored follow-up for at-risk neonates. Adaptations are mainly seen as increased left ventricular wall and septal thickness, reduced E by A ratios. If you see that these are blunted, these are low in velocity, and they are almost fusing because of their dysfunctions. Higher incidence of chronic fetal hypoxia, fetal acidosis, and fetal distress causes altered ventricular contractility. Here, the ejection time is much more, and hence can be diagnosed as a systolic dysfunction. Septal thickness, placentomegaly are other features. If the insult persists, further features of cardiac failure, such as cardiomegaly, poor contractility, low cardiac output, venous congestion, and effusions appear, depending on the severity and duration of cardiac dysfunction. Risk assessment of fetal heart failure is done by cardiovascular profile scoring, which has been validated as a predictor of prenatal morbidity and mortality. The score combines the following direct and indirect markers of cardiovascular function: fetal hydrops, which could be present in the skin, pericardium, or other spaces like the pleural spaces and the peritoneal spaces. Venous Doppler, which includes the umbilical vein and ductus venosus. Arterial Doppler, the umbilical artery. Cardiomegaly in terms of CT ratio. And cardiac function in terms of shortening fraction of ventricles, atrioventricular valve regurgitations, bi or monophasic filling of the pattern, bi or monophasic filling pattern of the flow pattern. The interpretation of the scores: a normal 10 on 10, if these are all normal, then the normal score is 10 on 10. For every feature seen, you deduct a point, either -1 or -2. Normal cardiovascular hemodynamics with no sign of congestive heart failure is a 10 on 10. Borderline or at risk when the scores are less than 8. These indicate early signs of cardiovascular decompensation. Scores below 7 strongly correlate with poor outcomes in high-risk pregnancies. critical is less than 5, a score of less than 5 is a strong predictor of severe perinatal morbidity and mortality. Other relevant organs essential for transition from the intra to extrauterine life are concerning the HPA axis with the hypothalamic pituitary axis or the neuroendocrine network and the immune system. These include adrenals, adrenal morphometry, and a corrected adrenal gland volume is supposed to be a very reliable predictor of preterm birth. The fetal adrenal gland plays a critical role in fetal lung maturation by producing cortisol, which accelerates surfactant synthesis and structural lung changes before birth. In prematurity, the immature adrenal cortex may not produce enough cortisol, increasing the risk of respiratory distress and chronic lung disease. An expanding adrenal gland volume, specifically hypertrophy of this inner zone, which is also called the fetal zone, correlates very well with an active mature HPA axis. Conversely, an abnormally small gland can signal congenital adrenal hypoplasia. There are two indices, D by D ratio. D is the anteroposterior depth of the fetal zone, and the capital D is the AP depth of the entire gland. So the D by D ratio is a very clear indicator of steroidogenesis by the adrenals. The corrected adrenal gland volume is volume of the adrenal by the product of height, depth, as well as length, divided by the estimated fetal weight. Fetuses with preterm birth have fetal zone enlargement and a higher corrected adrenal gland volume. Hence, these findings predict preterm birth to as close as 1 week or 7 days and is used for short-term risk stratification in symptomatic preterm labor. Studies have shown that fetal adrenal gland volume, fetal zone depth, and the middle adrenal artery pulsatility index differed significantly between pregnancies with preterm labor and asymptomatic controls of the same gestational age. So larger adrenal measures and lower the PI values were associated with earlier deliveries and higher NICU admissions. This is also because the fetal adrenal gland receives zone-specific blood supply, with the middle adrenal artery primarily supplying the fetal zone, which is highly active in steroidogenesis. Multiple studies with combinations of parameters of adrenal gland with cervical elastography, adrenal gland with the main pulmonary artery Doppler parameters, adrenal gland with 2D volumetry of the lungs have been studied, and consistently these ratios have been proven as good predictors of neonatal respiratory distress. Thymus is our next important other relevant organ. A larger thymus is an indicator of structural maturity, which correlates with higher surfactant production. A thymic thoracic ratio is compared with the normograms. Thymus is considered small when either the perimeter, the surface, the volume, or the diameter is below the 5th percentile for GA. Thymus, we all know, is absent in the DiGeorge syndrome. It is involuted in trisomy 21 and 18. It's a marker for immunoendocrine response. Small thymus is an early indicator of adverse perinatal outcomes in growth-restricted fetuses. Thyroid transcription factor, TTF1, is involved in the development of lung and expression of surfactant proteins during fetal life. Congenital goiters and teratomas can also cause tracheal compression, difficult deliveries, and high airway obstruction. These can be diagnosed by swallowing difficulties in utero, cardiac rhythm abnormalities, malpresentation, etc. Since the thyroid concerns homeostasis, in the neonatal period, hypothermia could be a factor contributing to respiratory distress. The fetal circulatory response to hypoxemia and asphyxia is centralization of blood flow in favor of brain, heart, and adrenals, which are the vital organs. This is at the expense of other peripheral vascular beds, and that is the basis of including splenic artery Doppler parameters. Studies have shown that there is a good correlation with prediction of fetal distress, especially in diabetes, fetal growth restriction, small for gestation age, and sepsis. High sensitivity of splenic artery PI cutoff values of 1.1 in predicting NICU admissions suggest that this parameter could be used as a screening tool to identify high-risk cases that may benefit from more frequent fetal monitoring or earlier delivery. The average fetal pancreatic circumference in the third trimester is about 70.7 plus or minus 0.6 mm. Pancreatic measurements were significantly higher in respiratory distress syndrome, neonatal pneumonias, and sepsis. Not to mention the kidneys. This is beyond the scope of this discussion. However, obstructive nephropathy, agenesis, or multicystic dysplastic kidneys, they all cause oligohydramnios and eventually pulmonary hypoplasia. Fetal anemia is a hyperdynamic circulation state. This is indicated by the peak systolic velocity of MCA. MCA is the middle cerebral artery compared with normal thresholds. A value of more than 1.5 MOM is predictive for moderate to severe anemia. This is important because it warrants considering intervention at this stage. Last but not the least, documentation of intracranial hemorrhage in cases of IUGR and for asphyxia. So the risk stratification actionables: diligent anatomy scan, identification of high-risk pregnancies, maternal or fetal or placental, prediction of preterm labor or prematurity, cardiorespiratory functionality and compromise to be assessed, serial follow-up. At this stage, we can explore in utero interventions, ideal delivery time after preparation for optimal lung maturity with antenatal corticosteroids, high-risk cases transferred to perinatal care, higher perinatal care centers. If we have the time, I can go in for some representative cases. This is a case of a 39-year-old essential hypertension on very, very high dosage of antihypertensives, a previous intrauterine fetal death at 16 weeks, also due to severe UPI. This USG was done at 29 weeks, which shows a high mean uterine PI, artery PI, a small thick placenta, a small but very thick placenta with a heterogeneous ecotexture. There was symmetrical growth restriction corresponding to 27 weeks at this time. Doppler shows intermittent absence of the end diastolic flow, reversed at the end of the in the fetal end of the umbilical cord. The cord was loosely around the neck. There were multiple criteria of fetal distress. Lung was coarse and echogenic. There was cardiomegaly. Volumetry was at 50th percentile of GA, but only till second degree intrabronchial artery could be seen, which showed high resistance on spectral trace. The E by A ratio was much lower, 0.7, with almost fusion of E and A waves, or at least E waves matching the A waves, which indicates loss of atrial compliance, reduced contractility, and diastolic dysfunction. The CVP score was high, which was 4 almost. The patient was transferred to Salmania, delivered by cesarean section at a birth weight of 825 grams on June the 12th. The baby is still in NICU with advanced respiratory support. Birth weight now is 1 kg. Another case of a diabetic mother. This baby showing hydrops, that is skin edema. The placenta was thick but heterogeneous in texture. There was cardiomegaly. She also had cervical incompetence and was very prone to preterm birth. The anatomy scan was normal. Interval growth scan at 29 weeks showed a functional cervical length of 2.3 centimeters. This baby's biometry showed large for gestation age, polyhydramnios. So she had multiple risk factors. We can focus here on the liver to lung ratio. Either the liver is hypoechoic or the lung is hyperechoic, but the ratio definitely is more than 1. Dopplers were within normal limits. Pulmonary maturity, AT by ET was 0.25. MPA, PI was 2.6. There was cardiomegaly with septal thickening and deviation towards the left. No systolic or diastolic dysfunction could be noted. The CV score because of cardiomegaly and high drops was 4, and hence high risk for adverse outcome. The patient was asked to follow up at a higher perinatal center. This was a case of a 43-year-old known case of thalassemia, previous 3 cesareans with a placenta previa of higher grade, and was posted for elective cesarean section. Patient was given antenatal steroids for improved lung maturity. At 35 weeks, biometry showed large for gestation age, normal pulmonary artery Dopplers, CT ratio was normal. However, there was fusion of A and E waves, which prompted further interrogation. The ductus arteriosus was showing high velocity flow. It was because of the steroids probably that there was an attempt of premature closure of ductus arteriosus. However, the patient went in for the elective surgery. Baby developed mild transient tachypnea at birth, managed well by the Manama team, and discharged on the 3rd day. Severe IUGR due to uteroplacental insufficiency, very high uterine artery PI, oligohydramnios, hardly any liquor, gross cardiomegaly, pericardial effusion, brain sparing, seen as increased end diastolic flow, umbilical artery showing absent or reversal of A wave, and end diastolic flow. MPA was, however, normal. The cardio profile risk showed high risk and transfer to Salmania. This baby was also delivered at about 1.7 kgs birth weight. This was the most recent case that I saw. So things are not organized, but this case had a pleural effusion. There was some peritoneal fluid, if you see this under the diaphragm, all were more than 3 mm in width. There was pericardial effusion, skin edema. So clearly a case of hydrops, though all the other indicators were normal. We are still yet to follow up this patient. So these are a few of my references. Thank you for patient listening. Any questions I would like to answer?
We can share this YouTube and groups because I think will be a maximum of 100 with log data. It's a Zoom has a capacity of this. So we think a lot of people want to do it. There are 100 people. Let me see if there are any questions on the chat. Just ask one more time if there are any questions.
Any questions I would like to answer?
There are no questions in the chat.
Thank you. Have a nice day.